I'd like to thank Dr. Walker for this great opportunity to present. Of course, would rather be in New Orleans for the annual trip. My name is Ramzan Zakir. I'm an interventional cardiologist from Robert Wood Johnson University Hospital. And the title of my talk is Subclavian and Brachiocephalic Stenting Indications and Techniques. These are my disclosures. So a little background on subclavian artery disease. This is from a series from Dr. Henry, looking at 357 patients. We see somewhat of a male predominance. The lesion types, more stenosis than occlusions. Location is significantly more on the left side as opposed to the right, and then you see some innominate lesions. And the etiology is most often atherosclerosis. So indications for treatment. Often we come across subclavian stenosis, but not all need to be opened up and treated. The patient has significant arm claudications affecting quality of life, usually associated with a pressure gradient of about 20. Subclavian vertebral artery steal syndrome is an indication to treat. Vertebral basilar insufficiency with symptoms such as ataxia, diplopia, syncope, vertigo, dizziness, nausea, and vomiting. Preservation of an ex-fem graft, as these patients may present with claudication, and you need to fix a subclavian in order to preserve the graft. Cerebral perfusion access and preservation of vascular access, AV fistulas. A common indication that we're seeing more and more is pre and post CABG lemma preservation. I think it's an important thing to do is once we've identified a patient to be a candidate for a bypass is to shoot the subclavian, because what you'll see in these recent studies that the prevalence of significant subclavian stenosis in patients scheduled for CABG range from 0.2 to 6.8%. And it could develop, into angina, and it can be, a important finding that can be treated either before, often before the bypass, or patients subsequently develop angina post-bypass. So how do we approach this from an endovascular standpoint, which is the major treatment modality for these stenosis and occlusions? You have sheaths and guiding catheters, which you can choose from. I more commonly use a sheath. You can go 6 French, have a 90 cm sheath, and you have to be familiar with your selective catheters, a JR4, vertebral, a VTEC catheter, Simmons, and so forth. As far as embolic protection devices, if you're working on the right side, you may have to use it. Off on the left, we don't use embolic protection device. And this cartoon over here is just showing how we approach the lesion with the sheath to get our glide wire across the lesion and get our sheath, through the lesion. You balloon it, and you see a key feature in G is that after you've ballooned it, you've again advanced the sheath past the lesion, and then you position your stent, and then you pull back your sheath. That's an important thing to do, because if your sheath is not across the lesion and you try to come in with a balloon expandable stent, especially a covered stent, the stent can come off and it can kick out your whole system, and that could lead to a lot of problems. How about your stent choice? So you have balloon expandables versus self-expandables. I like to use the balloon expandable if it's involving the origin, proximal portion. That gives you greater radial force, more accurate placement, and you want to avoid covering the vertebral and the IMAs. Now, covered stents, I think, are an excellent treatment choice for the more calcific osteal lesions. A study did show there's less fractures with covered stents in those osteal lesions, calcified lesions, than just a regular balloon expandable stent. Self-expandable stents are preferred in the mid portion of subclavian bends. They have a decreased chance of stent fracture if the lesion crosses the clavicle. So that's how I go about picking my stent choices for subclavian disease. Outcomes based on lesion type. For stenosis, the technical success rates are fantastic, greater than 90%, and have excellent long-term patency, 84%. Complications are rare. You can get distal embolic events, reperfusion, arm edema, CVA, infarct, or hemorrhage. What you find most likely is access site complications. Occlusions, the success rate does drop a little bit, anywhere from 50 to 87%, and the long-term patency is less than stenosis. And when you're dealing with the occlusions, there's more complications that could arise, such as dissection or perforation of the aortic arch. Now let's get to some cases. This is a patient with severe arm claudication, and you see a severe lesion in the proximal left subclavian artery. So this was approached with a femoral access, a JR4 catheter, crossed with the glide wire. Once I had the glide wire deep into the arm, then advance the sheath, and then perform pre-dilatation, advance the sheath across the lesion, like I mentioned above, position the stent, pull back the sheath, and deploy the stent. So here you see with my sheath pre-dilating the lesion. And this is, again, then I advance the sheath back up across the lesion, position the stent, pull back the sheath, deploy the stent. And our final angiogram shows an excellent result. This is a patient with severe vertebral basilar insufficiency symptoms. Approach was similar with femoral access and all the same steps. You see this one has more of a type 2 arch, so it's a little more complex with engaging, and a very calcific lesion in the proximal portion. Performed a pre-dilatation, positioned my balloon expandable stent, and you see that the stent expands pretty nicely. And here's our final angiogram showing a very nice result. Now this is a patient that underwent CABG and developed angina and had anterior ischemia. And you saw a hemodynamically significant lesion in the subclavian artery that's feeding that lima. So similar approach as we described above. Here's pre-dilating the lesion. Positioning of the balloon expandable stent. And here we have our final angiogram. Still away from the origin of the lima and the vertebral artery as well. So it's important when we're placing our stents to know, to make sure we're not jailing any arteries. And this patient's angina was relieved and is doing great. Now, techniques for crossing occlusions can be a little bit more challenging. In these cases, sometimes we have to have a multiple access in the groin and in the arm. The arm is very attractive choice for crossing occlusions, especially if they're flush occlusions, as you're not going to get much support from below. So this is just showing how the steps that we use to treat a osteal occlusion from the arm, with similar things with the shuttle sheath and then your wire and your balloon and stent. So here we see a prior stent was placed in the subclavian. You see a flush occlusion. So again, to be able to do this from the groin would be very difficult, as to get any type of purchase would be extremely hard. So this, we did an arm approach, was able to cross the occlusion, position our stent, and you see our final angiogram showing a nice result. The last case is an 82-year-old female, former smoker, severe left claudication and steel symptoms. Initial angiogram shows a proximal subclavian artery occlusion. Another view of the occlusion, fairly calcified, fairly complex occlusion. And you see a shot from the right, and you see the left vertebral artery filling. Nice picture of steel phenomenon. And the initial approach from the arm, you see that I went subintimal, I thought that would be a slam dunk from the arm, but you see we missed. So this required both access sites, and I was able to cross from below. And again, you could use similar techniques if you're subintimal in both planes. You could utilize reverse cart and cart type procedures in the subclavian as well. I was fortunate enough to be able to cross into the true lumen from below, so I didn't have to use any reverse cart procedure. And here you have your final angiogram, again, being careful not to stent across the IMA or the vertebral artery. So conclusions, these interventions have a high technical success rate, a fairly low complication rate, good long-term patency, and indications continue to be debated. Thank you very much for your attention.